Study Designs in Pharmacoepidemiology, Cross-Sectional Study, Part 3. Learning Objectives. Identify errors in cross-sectional design. Recognize methods to overcome systematic errors. Understand the advantages and the disadvantages of cross-sectional studies. We have two sources of error in cross-sectional study: systematic error or bias and random error or chance. Systematic error lead to a predictable and consistent departures from the true value due to problems in measuring outcomes or exposure. However, random error can lead to fluctuation around the true value as a result of error in measuring the exposure or outcome. Systematic errors, we have three types. The first one is confounding bias, in which there is a lack of comparability between the exposed and unexposed with regard to other factors that affect the risk of developing the disease. So in cross-sectional study, we don't have a control group. We're only taking a one group of participants and then assessing the exposure differences among them. So this can lead to confounding bias. Misclassification bias is another type of systematic error. This error occurs in classifying of subjects according to exposure of the disease. This includes interviewer bias, response bias, and recall bias. That's why in certain situations, we prefer, for example, if we're going to distribute a survey, we prefer to have the survey online or sent to participants by email so they don't have this pressure when they talk to someone. We call this pressure social desirability. So if we're going to ask the patients about their adherence, medication adherence, if there is someone who interviews them and this interviewer is the doctor that treats the patients or the clinical pharmacist that serve this patient, there will be a social desirability bias of answering certain questions not in the true answer. Response bias, this occurs always. If we want to, for example, to conduct a survey asking about the quality of life for multiple sclerosis patients, patients who respond to this survey maybe have a better life situation, quality of life, or their health is better than participants who were not able to respond to this survey. Finally, recall bias. These problems occur in all of retrospective data collection design. So in cross-sectional study, we are observing the patients and measuring the outcome and exposure at the same time and asking them about previous exposure. So who do you think will remember the previous exposure? Vulnerable patients, patient with the disease, or the patients that are disease-free? So recall bias occurs when participants who suffer from certain problem would be more likely to remember their previous exposure. The third type is the selection bias. Selection of subjects or their participation in the study is influenced by the disease under the study. This could be a sample bias. We choose non-representative sample selection. For example, we decide to assess the number of patients with multiple sclerosis, and we choose patients who come to the pharmacy. Multiple sclerosis is very rare disease. The prevalence of the disease is low. So usually people who come to the community pharmacy to buy medications, we will find a low prevalence of these patients. But why this happen? Because we choose a sample that's not representative of the true number of MS patients. Non-response bias and non-participant bias. Again, this refers to the fact that healthy patients, healthy worker effect could occur at any time. Healthy patients are able to move and go and participate in the studies, while sick patients, and especially critically ill patients or severely sick patients, can't be that efficient in participating in the study. So our sample becomes not representative in this case. Random error or chance, uncertainty introduced by small number of observations. So the solution for this issue is to increase the sample size. So this is a rule for you students, that increasing the sample size will minimize random error to the lowest possible scale. How to deal with systematic error, confounding bias, selection bias, misclassification bias. For confounding bias, we can do either restriction or stratified analysis, multivariate analysis. Restriction, which means that we eliminate the confounding factors. For example, we think that this variable is confounding, we eliminate this variable from the analysis. Or we conduct a stratified analysis. For example, we compare the analysis that we obtain between obesity and hypertension. We compare males and females. We stratify the analysis by gender or by age group. Or we conduct a multivariate analysis. So we include the confounding variables in our model to see if this will affect the relationship between exposure and outcome. Misclassification bias, we said, for example, one example of that was recall bias. We can overcome this by blinding. So when we present our surveys to the patients, we ask them about different exposures. So we don't focus on the main exposure of interest. So the patients will be able to remember without any bias to certain exposure. Selection bias, we need to overcome this by preparing our population of interest that should be defined independently of the disease of interest. So inclusion and exclusion criteria should focus on not on the disease status rather than on the parameters that will fit most to our patients. This slide shows the advantages and disadvantages of different observational study designs. We will choose the cross-sectional study to talk about. So in cross-sectional studies, there is a probability, medium probability of selection bias, high probability of recall bias because all the exposure measurements occur in the past. Loss of follow-up is not available because there is no follow-up in this design. Confounding medium, time required medium, cost is medium. So in general, these are the advantages and disadvantages. So if we want to assess if this study can measure the causality, causal relationship between exposure and outcome، أو خلينا نحكي باللغة العربية علاقة سببية بين exposure والoutcome، تعتبر weak study design. So if you wanna perform the strongest design for, if you notice in this table, the strongest study type to assess the causality is randomized clinical trials. This is followed up by cohort study, case control, and you can see that cross-sectional and ecological studies both provide a weak causal association or a weak ability to prove causality. But صح احنا عم نحكي انه علاقة سببية ضعيفة، ولكن sometimes the best design or the best thing you can do for certain type of problems is to conduct a cross-sectional study, and the associations should not be underestimated. Also, this could be a hypothesis for a future clinical trial. If we found a strong association between two variables, this can lead to a prospective clinical trial based on the hypothesis obtained from cross-sectional study. So quick summary, the advantages are it's cheap and quick studies. Data is frequently available through current records or statistics, ideal for generating new hypotheses. While disadvantages is that the main disadvantage is the temporal weakness. So there is no causal relationship because we don't know which occur first, the exposure or the outcome. This is the major drawback of cross-sectional studies.